Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 17th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. We are recording this evening's presentation so that you can revisit it again. Please feel free to tell your family and friends about it so that they too can view it on either the IBJI or the NSYMCA websites. Tonight's program, entitled Heel Pain and Beyond, Causes, Treatment, and Prevention, will be hosted by Dr. Carla Gamez. According to the American Academy of Orthopedic Surgeons, in a 2019 article in the health section of the Washington Post, about 2 million people each year seek treatment for sharp, stabbing, sometimes burning pain in the heel or arch of their foot. The most common causes of heel pain are plantar fasciitis, often felt at the bottom of the heel, and Achilles tendinitis, more likely to cause pain at the back of the heel. Heel pain may also be due to other causes, such as a stress fracture, tendonitis, arthritis, nerve irritation, or, rarely, a cyst. Because there are several potential causes, it is important to have heel and foot pain accurately diagnosed. Tonight, Dr. Carla Gamez will discuss how she helps patients to distinguish between all the possibilities to determine the underlying source of their particular heel pain. Dr. Gamez has been a podiatrist with Illinois Bone and Joint Institute for more than 20 years, and as a podiatrist, she is a medical specialist who diagnoses and treats foot disorders, providing care for the full spectrum of foot problems, including Sever's disease, hammer toe, Achilles tendon, arthritis, plantar fasciitis, fractures, and diabetic foot infections. She offers patients a range of treatments from ointments to orthotics to physical therapy and chilectomy, a surgical procedure to clean out arthritic joints and restore the foot to function. Growing up, Dr. Gamez was a runner and played on her high school tennis team. These activities, combined with contending with a broken toe that hadn't healed properly, sparked her interest in foot care and led her to become a podiatrist. She speaks fluent Spanish and participates in health fairs and other activities to promote health and wellness in local Hispanic communities. In providing care, Dr. Gamez looks beyond the foot itself, taking into consideration the patient's legs, knees, hips, and activities. She combines compassion and warmth with honesty, providing patients with realistic expectations about the likely outcome of their care. Her goal is to make each patient feel better and return them to their normal activities to the greatest extent possible. Thank you again for joining us this evening, and thank you, Dr. Carla Gamez, for your time and effort in putting together this presentation to teach us about heel pain and beyond. Now, doctor, please take it from here, and I can see your screen.
Hi, everybody. My name is Carla Gamez, and I will be talking tonight on heel pain and beyond, causes, treatment, and prevention. So the objective for tonight's lecture is to provide a foundational knowledge about underlying sources of heel pain with insight regarding prevention and treatment options. For each condition, we will review the following: symptoms, causes, treatment, and prevention. Patients who present heel pain are usually diagnosed with one of the following conditions. Each of these conditions will be discussed in this session: Achilles tendinitis, which is the back of the heel; tendonitis, and I'm going to concentrate on two certain tendons. One that's located on the outside of the ankle or the foot, and the other one that's concentrated on the inside of the heel and the inside of the arch area. As well as plantar fasciitis, always a fan favorite, which occurs at the bottom of the heel. Stress fractures, arthritis, nerve irritation, and others, i.e. cysts. This next slide has diagrams of the Achilles tendon. And I chose these two slides because it really shows you really what the Achilles looks like when it's injured and when it's swollen in relationship to the calf muscle, as well as in relationship to the back of that heel. And that heel bone, as you can see here, is called the calcaneus. Here's the, I'm showing with the pointer here, here's the Achilles tendon. And here, this area where it says nodule is actually the actual swelling in the Achilles tendon. And what the person feels and sees is the bulging of skin right outside and back of that heel bone. Achilles tendonitis. The patient presents with pain and tenderness to the back of the heel. It radiates proximally to the calf. Inflammation occurs secondary to the strain of the Achilles tendon. Pain and stiffness is very common along the Achilles tendon in the morning in most of the mild cases. Unfortunately, as the case and the pain progresses, pain along the tendon will worsen with activity, and especially going upstairs. And pain especially will occur after exercising. The tendon itself becomes thickened, and swelling then therefore unfortunately will be easily seen. I'm going to go back to the other slide and I'm going to show you exactly again what we're talking about. So this nodule is that actual thickening and swelling of that tendon. And if you can't come over here to the right of where it says the side view of the lower leg, you can actually see what happens with the inflammation. Okay, causes of the Achilles tendon. It starts with repetitive intense strain on the Achilles tendon. It can be seen with increased activity in high impact sports such as basketball, tennis, running. It also can be seen with tight muscles in the calves, sudden increase in weight. And I'm not talking about 5 or 8 pounds. I'm truly talking about the 25 pounds, 30 pounds, 40 pounds at that amount of weight that unfortunately can happen if it's in a very short time period, a year, 18 months, as well as wearing high-heeled shoes consistently. This is actually, people always answer me, well, how can that be? And it's because if the patient consistently wears those high-heel shoes, the tendon itself doesn't allow it to be becomes quite stiff, and it doesn't allow it to be flexible anymore. So as it's losing its flexibility, what happens is that when that patient goes to flat shoes or barefoot, it's a huge strain on that Achilles tendon, and it actually starts to tear. Other causes are certain medications and antibiotics that can cause tendon weakness. The one antibiotic that I would like everybody to know about, or the group of antibiotics, are called the fluocinolones. And the one in particular, or the couple that are in particular, are Cipro and Levaquin. Now, these two antibiotics, they are really good antibiotics, but they're really meant for severe infections in the body. And sometimes the physician who's prescribing them really doesn't have any other choice but to prescribe that to the patient. However, I just want to make sure that everyone is aware that unfortunately these two in particular, you know, can strain and affect the tendon, that when people come to see me 6 months, 8 months later and there's tears or ruptures, that unfortunately that's the first thing I ask is like, okay, what antibiotics have you been on in the last 6 months? Treatment for Achilles tendonitis. Basic treatment, physical therapy. I really believe in this, especially for this diagnosis. There's a lot that the therapists are trained to do that can really bring down that swelling and help take care of that inflammation of that Achilles, as well as in conjunction with oral pain medications. The oral anti-inflammatories, the non-steroidal anti-inflammatories can also help. Orthotics also can maybe recommended. As far as what I don't recommend here is, I don't recommend steroid shots, actual steroid injections to the actual Achilles tendon. There is a lot of data out there that unfortunately provide enough information that Achilles tendons that receive these injections have over a 30% rupture rate. So that's one area where I will not recommend steroid shots to. Most of these other issues that I'll be talking about, they can add to part of the treatment plan. Okay, I have now here the anatomy of the foot. And I put these two tendons here or these two slides to show the two tendons I will be talking in the next upcoming slides. If you look at the slide on the left, where it has all the names of all the tendons, that's a picture of the foot, the ankle and the foot from the outside view. And it shows all the tendons on the outside coming from the leg, going around the outside of the ankle and attaching to the outside of the foot, as well as the tendons on the top of the foot. On the other side, on this slide over here, these two pictures are muscles and tendons from not only the top part of the leg coming into the foot, but as well as the inside of the leg and coming around, those muscles converting themselves into tendons and coming around and attaching to the inside of the foot and the arch area. Okay, so peroneal tendonitis. Peroneal tendonitis is an inflammation to the strain of the peroneal tendons. Now the peroneal tendons, if I'm going to just flip back just for a second, and these are the tendons that are here on the outside of that leg, coming all the way around the outside of the ankle and coming and attaching towards the outside of that foot. Okay, so just so everybody can get their bearings. This occurs when there's an increased load and overuse of the tendon while rubbing against the bone it's attached to. It's located on the outside of the leg, ankle, and foot. Symptoms occur when patient feels the pain is located in the back of the leg, outside of the ankle, and in the foot. Swelling can occur and can be seen around the ankle and to the side of the foot. Patient will feel, unfortunately, an instability of the ankle when they're bearing weight. Causes for peroneal tendonitis. They typically occur with overuse injuries, sudden increase in training, particular weight-bearing activities, improper training techniques, inadequate footwear, and imbalance in muscle strength of lower limbs. What I mean by the imbalance in muscle strength is that one side of the leg and foot, certain muscles may be stronger than the other side of the leg and foot. And unfortunately, then the more stronger muscles will overpower the weaker ones, and then we can get into injuries. As well as the sudden increase in training, I see that a lot too. Treatment for this diagnosis is a lot of times it's immobilization, pain medications, anti-inflammatories, physical therapy, and actual bracing. This diagnosis can be debilitating, and a lot of times, honestly, if it's pretty severe, I will put my patients in a mobilizing cast removable brace for a few weeks, and then follow it up with physical therapy. Prevention: wearing appropriate footwear. This actually, people will have a lot of these injuries when they're walking a lot or in flip-flops or certain sandals that are not supportive, and they're walking a lot in uneven terrain. So because there's no support on either side of that shoe, they can easily just, unfortunately, rotate that foot and cause a strain in that tendon. So I always recommend wear the appropriate footwear. Also, prevention for this is stretching the calf and muscles to the leg and foot. You'll be hearing a lot of stretching comments throughout this lecture. I cannot emphasize so much that it's super important to have, honestly, to stretch your entire lower extremity, your legs, and on the inside, outside of the legs, as well as your ankles and your feet. Okay, my next tendon is the posterior tibial tendon, which is also known as the PTT. And this is the tendon that's on the opposite side of the ankle from the peroneals. So it is on the inside of the leg and goes around the ankle into the arch of the foot. So what is posterior tibialis tendonitis? It is inflammation and strain of the tendon. The PTT passes down the back of the leg inside of the ankle and into the arch of the foot. The symptoms people present with are pain on the inside of the ankle traveling to the heel and inside the arch of the foot. Swelling can easily be visible, and there's obvious weakness with rotating foot. When people come to see me, I'm going to just add, and people come in and they say, oh, I have heel pain, heel pain. I specifically really hone in on this diagnosis. A lot of times it's not just the heel pain in what we think of the plantar fasciitis. A lot of times people will present with this diagnosis and actually will really not have anything to do with plantar fasciitis. They're very close in contact, and swelling really occurs on the inside side of the heel bone, not so much in the bottom of that heel. So those are pretty distinguishing observations, as well as weakness with the rotating the foot towards, especially towards the midline of the body. Long-term result with this, if this really is not taken care of, the patient can and may develop a flat foot because of this tendon. And how does this happen is that the posterior tibialis tendon, its main function is to not only bring the foot in towards the midline of the body when we're walking or running, its function is to hold up the arch of the foot. So it's a stabilizing force. However, if this tendon becomes chronically weak, it will not be able to hold up the inside of that arch, and that person unfortunately will develop a flat foot. And it usually occurs unilateral. You really don't see it on both sides. It's usually just seen on one side at a time, to be honest. So that, unfortunately, when you get to that stage, that's a late stage, a late occurrence. Causes: overuse, injury from repetitive high impact sports, poor conditioning, weight gain, inappropriate footwear, and genetics. Some people are just born with flat feet. The injury from repetitive high impact sports, and these are usually the sports that are the cutting sports, the racket sports, whether it's tennis, racquetball, paddle. Paddle is very big. I love the sport myself, but there's a lot of injuries that go with the paddle, especially this entity, to be specific. And while we're on it, poor conditioning. People will start a new exercise program or start a lot of these high impact sports and will go into it and really won't consider really properly conditioning not only their feet, but their legs. And you see these tendons come from the muscles in your calves. So if you're not really strengthening your leg muscles, that's going to play into how these tendons function in relationship to the foot. So I'll be emphasizing the need to really condition properly when you're doing any of your extracurricular activities. Treatment for posterior tibial tendonitis. Treatment is, what I recommend is, even for mild cases, I'll recommend an over-the-counter arch supports. Sometimes the Dr. Scholl arch supports that you can get over the counter at any of your pharmacies will be just enough for the mild cases. However, as this tendonitis becomes a little bit more severe, I do recommend a custom accommodative orthotic, so orthotics built just for you. Along with that, I also always recommend physical therapy for this diagnosis, anti-inflammatory medications. This will allow to bring down the swelling in these tendons. For severe cases, again, immobilization. For severe cases of these tendons that also cause these chronic flat feet, sometimes it's necessary surgery, but I I won't recommend surgery until really all the conservative approaches have been exhausted. Prevention. A lot of these orthotics really can help to prevent the acute tendonitis from developing into a chronic situation. As well as I stressed before, strength training for muscles to leg and foot. Plantar fasciitis is my next topic. This is as I said, a hot topic, and it's been a hot topic for, my goodness, for over 20 years. So here's a diagram of what plantar fasciitis looks like. The plantar fasciitis is basically inflammation of the plantar fascial ligament. And that ligament starts at this heel bone, again, which is called the calcaneus bone, and comes across and attaches all the way to the ball of the foot. And just to review a little bit of medical terms, tendons are structures that we can move through our mind. Ligaments are parts that are structural components. We cannot control or move ligaments. They're only there to hold up joints and hold up the bones. So as far as the plantar fascia goes here, this becomes injured when there's a strain that is placed truly right around the heel, right at that origin where it starts. And there's also a picture of a heel spur, which I will speak on in a few slides coming up. But the only thing I want to point out here is on that heel spur, if you notice, that heel spur is parallel to the ground, not perpendicular to the ground. All right. All right, the patient who comes into my office with plantar fasciitis, it is truly an inflammation of the bottom of the heel. It truly is the most common foot complaint out there. Early symptoms. The patient will present with initial pain after rising from sedentary position. Pain lessens as the patient walks it out. Pain is also exhibited and is worse in the morning, right after the patient gets out of bed with the first few steps out of bed. After that, the patient walks it out and the pain subsides. Later on, as this condition progresses, the pain can occur throughout the day, especially after prolonged activity. For these later symptoms, that's really when I'll recommend the custom-made orthotics. Heel spurs. Heel spurs, I can't tell you how many people come into my office and say, "Oh, doc, I have heel spurs. That's why I have the pain." And to be honest, heel spurs are the result of a chronic plantar fasciitis condition. Typically, they do not cause the pain. And if you remember from the previous slide, that heel spurs are calcium deposits that develop in the line of the tension of that ligament. And they are parallel to the ground. They're not perpendicular to the ground, so you're not truly stepping on something pointy. But what hurts is obviously the inflammation and the bruising of the bone. All right, causes for plantar fasciitis. Causes. There are a lot of them, but here are some of the most common ones. Increased activity, walking, standing, stair climbing, wearing high heels again, gaining weight, also high arches, flat feet, tight Achilles tendons, some type of repetitive impact to the heel, or even a severe isolated episode. The median age for this condition is ages 40 through 70, as well as pregnant women in the late term. So I do need to just add to this slide, in the first 6 months of lockdown of the pandemic, I really saw an increase in plantar fasciitis. And I do want to emphasize that because on that increase, people weren't allowed to go to the gym, so people were either running or walking outside a lot more than they had ever been. So typically a patient would tell me, oh, they used to walk 3 times a week at maybe 4 miles, anywhere between 2 to 4 miles at a time. And all of a sudden they've increased the load and they're now walking 4 to 7 miles every day. So that's what I mean about increased activity in a short amount of time. And that unfortunately can cause a strain and tear into that ligament. And so if you remember, that ligament's at the bottom of that foot. As far as ages 40 to 70, I mean, I will see plantar fasciitis, to be honest, in all of the ages from 20 to 80, but ages 40 to 70 are really the norm, is what I would say. And that's typically, as we do grow older, our tendons, our ligaments, they lose its flexibility. But I do find people starting new exercise routines and not training properly, and unfortunately things start to tear. Pregnant women, I'll see them late term with plantar fasciitis, and that goes right and coincides with the amount of weight of carrying their children to late term. That weight will unfortunately also press onto that ligament and will cause that inflammation. All right. Treatment. For the initial mild cases, I always say ice and stretching to the affected area, the heel. As the condition worsens, I'll recommend highly physical therapy, orthotics, oral anti-inflammatory medicines. Here's the steroid shots that I would recommend, not on the initial visits, and I'll explain in just a moment why, but I also recommend massage therapy and yes, acupuncture. Probably last decade, I really have had people try acupuncture, and I've had some success, a lot more than some success with it. As far as the physical therapy doesn't just include for me a home exercise program. If I'm recommending physical therapy, it really is that I want the trained physical therapist to really look at that injured area and see what else can be done and how to reduce that inflammation and to strengthen the leg and the feet, which does play into the demise of the plantar fascia as well. As far as steroid shots are concerned, steroid shots are they have a good place in some of these conditions. And for plantar fasciitis, I will offer a steroid shot right where that area where it's the tissue is swollen and inflamed, and you will get immediate relief for the most part. But I try not to do that initially because I really believe this is more of it tends to be a bit of a Band-Aid. And when I'm looking at this as a whole, I just don't want to treat the condition with a Band-Aid. I really want to have that patient not only get over that episode, but prevent it for the future, okay? Massage therapy, also very good, and as I stated, acupuncture. Prevention. Stretching, stretching, stretching. Maintaining good muscle tone in legs and feet, proper nutrition, and good posture. Let me just touch upon the stretching comment. I tell my patients that what happens if you don't brush your teeth every day? You'll, unfortunately, will develop tooth decay. And with that tooth decay, you'll need to fill up the cavities and deal with all the unfortunate results from not brushing your teeth. And in the same concept, I cannot tell you how much I emphasize stretching, stretching, stretching. If one maintains a good stretching routine every day, 5-10 minutes at most. A lot of these conditions, including this one, really can be avoided. I honestly believe that. And good posture and proper nutrition, hydration goes a long way as well. Okay, next on the list are stress fractures. Stress fractures can occur anywhere in the body, but I'm going to just stick to the heel bone, the calcaneus. And I have two pictures here. Picture on the left side of a crack of, actually a break of the actual heel bone from bottom all the way to the back, as well as another diagram where it says calcaneal stress fracture right here. And you can see it's just a tiny crack in back of that heel. You can also have just a tiny crack in the bottom of that heel too. All right, what is a stress fracture? A stress fracture of the calcaneus is a small break in that heel bone. The symptoms are pain, swelling, and tenderness to the bone. Pain presents at the start of the activity, and however, pain, you won't feel the pain once one ceases to get off the feet or the foot in particular. Pain is also worse at night after activity. And this is definitely different from any of the other conditions we've been talking about. Causes. Again, that I think in every cause of these conditions, overuse is right there. But overuse secondary to repetitive actions in certain high impact sports, running, basketball, tennis, dance, incorrect training or technique, poor diet, and low vitamin D levels. I'll get to that in a minute. As far as stress fractures are concerned in the heel, I'm going to relate it a little bit to the plantar fasciitis that I just spoke on. So on the plantar fasciitis, when it's really severe and you have pain all the time, patients can actually bruise their bone. And bruising their bone can also lead to stress fractures. And that has to do also with the secondary to repetitive actions. I will see, unfortunately, a good handful of stress fractures to that heel bone. I'm going to give an example for dance, Zumba, hip hop. People starting out in these extracurricular activities will start gung-ho and will just do all the techniques, will really want to just get into the spirit of the dance, and will overdo it. That amount of pounding on that heel bone can cause a tiny break in that heel. Low vitamin D levels. I put this in here because in the last 18 months since the pandemic started, I really saw a lot of increase in my patient populations with stress fractures. And yes, I knew it was from overuse, but there was a lot of people I was seeing. So I started doing levels and taking blood samples or sending them to the lab and looking at the levels, the vitamin D levels and their calcium levels. And what I found was that a lot of these patients presenting with stress fractures were extremely low levels of vitamin D as well as calcium as well too. And calcium and vitamin D levels are really important to keep your bone strong. And if it's not kept up, that the bones are then soft. And if the bones are soft, unfortunately, they're going to be susceptible to breaks. And if you're doing you're running or you're power walking or you're doing any of these other high impact sports, well, you're going to end up with these stress fractures. So I do, if you feel that this applies to you, I would recommend before taking just any over-the-counter vitamin D capsules, I would talk to your primary care physicians. Just get some blood work on, see where your vitamin D levels and your calcium levels are. I mean, it's also good to know. You'll be surprised. I've been quite surprised in the last 18 months with a lot of my patients and having levels come at a very inadequate levels. Treatment is basically stopping activity which causes pain, applying ice to the injured area, 10 minutes at the most, and as well as seeing your physician for an x-ray or possibly even an MRI to diagnose. Sometimes these stress fractures are not easily seen on just a two-dimensional x-ray. As well as further treatment is immobilizing the foot anywhere from 2 to 8 weeks and stopping the physical activity as long as the physician suggests. I'm going to go a little bit on, talk a little bit more on stopping activity which causes the pain. This is a pretty difficult request for a lot of my patients to follow through, especially on a lot of my patients that are just love and are addicted to working out and just feel the need to work out. But I always try to emphasize that to my patients. I always try to bargain with me. Well, maybe I can do bike riding, or maybe I can just not run 5 miles. I can run 2 miles. But I'm telling you, these stress fractures can lead to actual breaks, a full break into the bone. So please, if this is you, please stop the activity, as well as don't restart the physical activity until the physician suggests. A lot of times my patients will be in boots for maybe 10 days and lo and behold, they'll feel so much better. However, that doesn't mean that that break is completely healed just because the patient doesn't exhibit the pain anymore. So moral of the story is listen to the request of their physician. Arthritis. Arthritis is a condition of joints, and arthritis can happen anywhere in the body. I'm going to just talk about the arthritis related to in and around the heel area. Arthritis in general is inflammation and degeneration of joints. Most common foot and ankle joints that are affected by arthritis are the ankle subtalar joint, which is the joint below the ankle, the midfoot arch area, and the great toe joint. Symptoms: people will present with tenderness and pain, limitation on movement of the joint, stiffness in the morning, moving that joint, and at later stages, swelling of that particular joint. There are several types of arthritis. All involve inflammation and swelling in and around the joints and the soft tissues it's associated with. The most common type of arthritis is osteoarthritis. It is the age-related arthritis. It is the wear and tear, mechanical reasons for that degeneration of that joint in particular. Rheumatoid arthritis is an autoimmune disease condition. It's systemic and it affects joints. As it affects joints, those joints in particular can deteriorate, and you will get the same symptoms as osteoarthritis. You'll get the swelling, you'll get the pain with movement. The next cause here is gout. Gout is a buildup of the uric acid in the body. And uric acid is the byproduct of the breakdown of proteins. So normally our body should be secreting out all the byproducts, all the uric acid out of your body. But sometimes for secondary to dietary and nutritional limitations, that uric acid will build up in the body, and specifically it will build up in joints. And when it does, it will, in essence, the acid turns into crystals, and the crystals will sort of eat away a little bit at that joint, and it will have that arthritic presentation, and you'll get the swelling and you'll get that limitation and pain with movement with that joint. The last cause I'll be covering is post-traumatic arthritis. And this occurs after a severe injury to the said joint, resulting in an abnormal anatomical position from that injury. So if the joint does not move properly the way it's supposed to, well, then it's going to wear out sooner rather than later. And again, you'll see limitation of movement. That limitation of movement will bring, unfortunately, more destruction to the joint, and you'll get the swelling and the pain along with it. Treatment for arthritis. Sometimes in certain joints, physical therapy can help. There's a lot of modalities that physical therapists can apply to these arthritic joints. It will be a very different physical therapy experience than therapy when it's recommended for a tendonitis. There's other modalities that can be done to relieve the swelling and the pain, as well as, aside from physical therapy, rest, anti-inflammatories, cortisone injections have a good place for this, as well as, unfortunately, ultimately is surgery that can be addressed and that can address the arthritis. Diagnostic test. To really know whether you have arthritis or not, it's really recommended to get X-ray images as well as a gait analysis. And a gait analysis is conducted by the physician, and it highlights abnormalities in one's stride or walk. And visually, we know how each joint should function, and you put it all together, and certain areas can be highlighted as well, and they can give us more answers on how severe the arthritis is, as well as coinciding and viewing of the X-ray images of the patient's joints. Nerve irritation. Nerve irritation can apply anywhere in the body, but again, I am going to limit this to the nerves irritation that affect the heel and the ankle area. This itself can have a whole lecture onto itself, so unfortunately I'll limit it a little bit to this lecture. So the three primary conditions that affect the heel area are tarsal tunnel syndrome, peripheral neuropathy, and sciatica. Tarsal tunnel syndrome is the compression of the posterior tibial nerve located behind the inside of the ankle, and patient's symptoms are numbness, sharp burning pain to the ankle and the heel, weakness, significant weakness in the ankle and the foot and toes. Causes, it's a pinched nerve, and that is located basically behind the inside of your ankle and can get wedged inside that ankle joint, and which also causes the pain. Treatment for this is anti-inflammatory medicine. Steroid injections do relieve a lot of that pain. Physical therapy as well. And for this one, if it progresses to the late stages, truly surgery is probably your only treatment, but the patient will know when surgery is necessary. Peripheral neuropathy. Peripheral neuropathy is weakness and numbness and pain from nerve damage. And it can be seen in the hands and feet. Symptoms. Patient will feel pain, a pins and needles sensation, numbness, and weakness. Most causes, the most common cause is, honestly, it is really diabetes, but you can also get the peripheral neuropathy from injuries and infections in and around the joints or soft tissues around the joints. Treatment. This is a hard one. Treatment can help, but it cannot be cured. Once that nerve is damaged, there's really no cure for it. And all the medications will do, it will help to relieve a lot of that pain that can be associated with nerve damage. This actually requires an actual medical diagnosis through testing and imaging. So MRIs can help. A test called the NCV EMG test, which is a test for nerves, and it's not the most comfortable test, but it will it will diagnose it effectively. Medications can also include antidepressants and pain medications as well. Sciatica. Sciatica, it's pain that starts in the spine and radiates around the sciatic nerve from the lower back to the heel. It typically affects one side of the body. The cause is when a herniated disc or bone spur in the spine presses on the nerve. So why do I mention this on a lecture on heel pain? Well, I tell you, I will see a lot of patients that come in, and I will go through the other conditions that I've talked about, and I'll start ruling things out, and I just can't, the patient doesn't get better, and I'm doing tests, I'm sending them and exhausting all the conservative approaches, and then I'll ask, or they'll relate to me, the patient will relate to me that, oh yes, I do have a, low back pain, or and I have this pain that actually the pain starts in the back and goes all the way down to that heel. And that pain, honestly, is coming from that pinched nerve from the lower back. Treatment. As a podiatrist, there's not a whole lot I can do for this diagnosis, this condition, but I do advise my patients to consult their orthopedic back specialist surgeon to seek further treatment and help. All right. Other conditions affecting the heel are, I put here, cysts. And I chose 2 cysts. There's a lot of all different types of cysts, but I chose the 2 most common cysts that affect the heel area to talk about. The first one's the ganglion cyst. And the ganglion cyst in general, it's a fluid-filled lump or cyst that arises from joints or tendons. And this can occur anywhere also in the body, hands and toes and the foot in general. But I'm gonna relate it to my topic here that I'm talking about. And these cysts can be found in the ankle and in the subtalar joint. Subtalar joint is a joint below the ankle. Symptoms are swelling and nodule or a lump, cyst, and pain. Causes, again, the overuse activity. I think we've seen this with almost every condition I've talked about. This one also can result from trauma, infection, and inflammation. Treatment for these cysts are immobilization, but you can also, these cysts can be, at least if they're superficial, they can, aspiration can help. But ultimately, these tend to go to surgery if they're really growing in size and becoming debilitating to the patient's joint. Fibroma. This is my other cyst that I would like to talk about. And a fibroma is a benign solid lump or cyst on the arch of the foot. Symptoms are patient presents with pain and swelling at the bottom of the foot, anywhere from the heel to the toes. It typically arises from the plantar fascia, and that's why I brought it into this lecture. Causes: repetitive or traumatic injury to the bottom of the foot. Genetics as well, i.e. they're common in certain Northern European descent. Certain heart medications can cause this, i.e. some of the beta blockers medications. Long-term alcohol abuse as well. Treatment for these. In most cases, topical pain creams and steroid injections do help to reduce not only the pain, but reduce the size of the actual cyst. Physical therapy as well. Custom orthotics will help to ease the pain or offload the lump from the patient's arch area. Stretching, always a good one, and surgery. but there's a caveat with this, the surgical treatment on this. Patients should know that there is a high reoccurrence rate even after the fibroma cyst is excised surgically. And so for that reason, I really recommend surgery be the very last attempt in treatment. I will do surgery to remove these, but they need to really be extremely large and painful. When I say large, I'm talking about 3 centimeters length and width, and height of a couple centimeters as well. So basically, the patient's experience is they're walking on this big ball on that arch area. So with that being said, then I will inform my patient that the risk of having this taken out also means that it can just come back again, unfortunately. But yes, I think that is, with that being said, that wraps up my lecture here, talking about heel pain and beyond.
All right. Well, thank you, Dr. Gamez. We've got a few questions. I know we're getting right towards 8 o'clock, so I won't keep you for too much longer. But someone asked us, once you have plantar fasciitis, and even after it calms down, are you always prone to this for the rest of your life?
That's a great question. And I will tell you, yes and no. And I say yes and no, it is more susceptible to tearing, that I will tell you. But I go back to that one slide that says stretching, 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 okay? And honestly, if you can get into a good 10-minute stretching routine, you can return to your full activity, whether it be running, whether it be playing paddle tennis, whether it be playing basketball, volleyball, you name it. It can be done. The reason I became really interested in plantar fasciitis because I actually, I had it, and I got it actually late term. I was pregnant with twins, and it just stretched out and tore my ligament. So I'm speaking from personal experience on this. So it does, to answer that question, yes, you are more susceptible of having a reoccurrence to it, but honestly, get the arch supports, get the custom-made orthotics if it applies to you, and stretch, stretch, stretch. I can't emphasize that enough.
Great, great. You had mentioned topical creams to help with a certain type of cyst. Someone is asking, would topical creams be something that you might use for plantar fasciitis instead of having to take Advil all the time?
Oh, absolutely. I will, there's a place for these, for Advil, for Aleve. There is a place. I typically don't like to have my patients on those medications more than a few weeks, maybe a month, only because those medications can really eat up that stomach liner. And, there's a lot of report out there that patients will develop these silent ulcers. So I really do recommend the topical pain creams. The good ones that are over the counter, the one that I really like a lot is actually Voltaren gel. It was a prescription topical for many, many years, but it's really safe. I recommend it along with icing, and those two can really help a lot. As far as more prescription type of topicals, I also do that too. There is on those prescription medicated creams, there's probably about a 2% to 3% absorption rate that it maintains primarily it stays locally, but it does get absorbed a little bit in the bloodstream with that. But I will still prescribe those very often.
Great, thank you, thank you. A question for Achilles tendinitis. Would you recommend K-tape for someone to use when they've got Achilles tendinitis? Or is that more a physical therapist's question?
No, well, yes and no. I do recommend it wholeheartedly. I really, really do, because K-tape is, especially with Achilles tendinitis, once you're kind of coming out of the acute phase, and I know the physical therapist will use it a lot. I will recommend the therapist to use it a lot, especially on my athletes, as we start to have the patients return to their sport, or even return to, if they are in a job or profession where they're standing a lot too. I will recommend the K-tape. It's a good way of somewhat immobilizing that tendon and taking that tension away, and it still allows that tendon to continue to heal from that initial injury. So yes, I would recommend it.
Great, thank you, thank you. A lot of people are asking about shoes. Is there a particular type of shoe that you recommend, or a brand that you recommend, or a specific shoe that you might want to get with orthotics? When you've got orthotics.
Shoes, that is a very somewhat personal question. And I found that I used to recommend a lot of shoes, but then it also has to do with the, some people have a foot structure that's very rigid. Some people have a foot structure that's very flexible. And so shoes are meant, some shoes are rigid and some shoes are flexible. So I do kind of stay away, but if I'm going to take, for instance, athletic shoes that are, for instance, Brooks tennis shoes. They're a great pair of tennis shoes, but they're real stiff. They're not for everybody. Whereas, and the new style that are in vogue are the Hokas. And Hokas are great, but they're not for everyone too. So as far as, I would rather have my patients, to be honest, I would rather have my patients get a good, I start out with a good over-the-counter insert, which I like. For instance, I recommend a lot of Superfeets. You can go on Amazon and they'll have different degrees for severity of heel pain or arch pain. And you can put those Superfeet into your shoes. There's also some that are meant for dressy shoes as well. Hopefully I've answered that question.
Yeah, I think you have. Someone was asking, how do you spell the topical cream that you recommend?
Oh, the Voltaren.
Yes.
VOLTAR, Voltaren, IN.
Gotcha.
Me.
Okay, so they can probably Google it and find it.
They can, and it honestly, it is front and center from every pharmacy that I've been in. You name it, Osco, Walgreens, your mom pa pharmacies, your health stores as well. And they have them, they come in either 10 gram, 30 gram tubes, and it's a tube. So you can't miss it.
Excellent, excellent. And several people have said it's VOLTAREN.
Ian, so, thank you.
Sure. Well, thank Bev and Sylvia and Mary for that.
Great, thank you,
great.
You three.
There you go. And it's after 8 o'clock, and so I don't want to keep people too late. I know there are still a number more questions. As Dr. Gamez said, see your doctor, see your physical therapist. People are asking about different stretches to do, different strengthening exercises. And luckily, Dr. Gamez's information is right here on the screen. You can make an appointment with her, and she can help you individually and really answer all those questions that you have, or send you to the right person if she thinks you need physical therapy or something like that. Would you agree with that, Dr. Gamez?
Absolutely, absolutely.
Excellent. Excellent, great. Well, Dr. Gamez, thank you very much. Thank you all for joining us tonight. Our next program is August 25th. That's another Wednesday at 7 p.m. It's called Knee Pain and Injuries with Dr. Gregory Portland. So Dr. Gamez, thank you very much for joining us this evening. Thank you to all of the great people. We had a lot of people who stayed on the whole presentation. So thank you all for sticking around tonight. Thank you, Dr. Gamez. Everybody have a great evening.
Thank you, everybody.
Thank you. See you next time.
Bye-bye.